Presenting a case of tracheomalacia managed with tracheal T-tube, I would like to present a case of acquired tracheomalacia, an elderly female patient managed with tracheal silicone T-tube insertion. Patient is about 65 years and known case of brain stroke due to CVA. This patient underwent tracheostomy following CVA, likely for prolonged ventilation and airway protection. Over the last few months, patient neurological status improved. Patient is conscious oriented, ambulatory. Swallowing is adequate and no aspiration episode. Each time the tracheostomy tube was tried to remove, patient developed breathing difficulty, oxygen saturation dropped, symptom relieved immediately after reinsertion of tracheostomy tube. This raised suspicion of any dynamic airway problem rather than neurological or vocal cord dysfunction. On clinical examination, there is tracheostomy tube is in situ, stoma healthy, no stridor at rest and with tube. No sign of aspiration and chest examination was normal with x-rays also normal. Now we plan flexible bronchoscopy in this case. There is bilateral vocal fold are mobile and normal. Subglottis is normal. Trachea showing marked anteroposterior collapse during expiration. Tracheal lumen significantly narrows dynamically. Findings were consistent with acquired tracheomalacia, likely secondary to prolonged tracheostomy tube or long-term pressure effect of tracheostomy tube and cuff. So in this case, diagnosis is acquired tracheomalacia causing dynamic airway collapse, leading to failed decannulation despite normal vocal cord mobility. We plan tracheal T-tube insertion in this case because this provide internal airway splinting and maintain tracheal patency during respiration, allow phonation also, and easier suction and care, and it is reversible and adjustable, and it's give better quality of life compared to permanent tracheostomy. Here, rationale for T-tube in this case, it is recurrent decannulation failure case, required dynamic tracheal support, normal vocal cord mobility is there, patient neurologically stable and walking. Long term airway support needed without external tube. So, putting here this T tube is importance of considering tracheomalacia in patient, repeated failed decannulation. Roll up bronchoscopy is gold standard for diagnosis in this case. And tracheal silicone T tube as an effective, safe, patient friendly solution in selected cases of acquired tracheomalacia. So, take home messages. Recurrent decannulation failure with normal vocal cords should always prompt evaluation for dynamic airway collapses. What are the other options? Long-term tracheostomy, surgical tracheal reconstruction, as in this case, high-risk elderly cases already having CVA, tracheal stenting that may migrate, and fourth is the silicone tracheal tube that is preferred option.